Hello and good morning. First of all, I would like to thank the organizers for giving this kind opportunity to present on such an important topic of Ivus and calcified lesions. And it's always an honor with Dr. Seth and Dr. Mintz and my friends here in the panel. So I think for the last 2 days, we've been talking about Ivus in various situations. So there is no doubt that Ivus helps in complex PCI. And I believe wherever there is calcium, there is complexity. They are best buddies. So calcium means complex. So if we use Ivus in complex PCI, definitely we reduce the MACE by 50%, even if they are not a subset of calcified patients. I mean, if we have subset of calcified patients, the decrease in MACE will be even higher and the safety will even be better. So there are some concerns about Ivus, considering Ivus and OCT is a big debate. Some say it is difficult to analyze Ivus, but I think we have to look at a particular technology enough to make it easy for our eyes to understand it. And some say that calcium thickness cannot be measured on Ivus. That is true, but we do not need to measure the calcium thickness. We need to expand our stents, which is not dependent upon calcium thickness. We can measure calcium volume, which is generally enough. And there is a concern that vessel is oversized on Ivus, which is probably not true. So all these papers, 95% are Dr. Mint's papers, so we are honored that he's there. So we can see calcium very nicely as on the left panel and somewhat more with more difficulty on OCT. And even the calcified nodule, which is very bright, is seen very nicely on Ivus and also on OCT. So why do we do Ivus? I mean, if we cannot measure thickness, so should we use Ivus for doing these complex PCIs? I think the answer is yes, because you don't need thickness to predict stent expansion, as has been shown by the colleagues in Colombia. First of all, the most important part of this algorithm is that there should be moderate to severe angiographic calcium. Unless there is moderate to severe angiographic calcium, then you go on to Ivus. If there is no calcium on the angio, then generally your stents will expand with an exception of calcified nodule without any angiographic calcification. So after that, if the calcium score is more than 2, of course you go to atherectomy based strategy and then go step by step from there to have good stent expansion. So I'll just show a few cases. So very briefly, so the case 1 is a 72-year-old male presenting with stable angina and normal ejection fraction. So you look at this distal left main, you see a very hazy picture in the distal left main, which is somewhat more clear in the cranial projection that there is something bad in the distal left main and in the mid LAD. You put an Ivus probe down and you see there is a large calcified nodule which is almost occlusive in the whole of the distal left main. And now you know you how to modify this. There is a calcified nodule. You need to decrease the volume, shave it off as much as you can. And in the longitudinal view, we see very nicely in the distal left main a calcified nodule and also a tight lesion in the mid LAD. So you start with the rotablator, a 1.5 millimeter burr, probably mainly for the mid LAD, and then you use a 2 millimeter burr for the distal left main, shave off as much volume as you can, follow it up with an angiogram, and you see that funny picture in the angio is gone, and after that you dilate with a cutting balloon 3.5 to create some space, do a crossover stenting with a 4 millimeter stent. Shaving off also helps that we don't have enough carina shift on the circumflex and we can keep this case relatively simple. And then we see in the pre and the post, we see some malapposition around the nodule because it will never be possible to have a completely opposed stent in these eccentric calcified lesions. But what is important is to get an appropriate area, which here is about 13.26, which is fairly acceptable, and a good stent expansion in the longitudinal projection. The case 2 is sometimes somewhat little more dramatic. He's an 82-year-old patient with diabetes and hypertension who is a known case of CAD. His first angiogram was done by Dr. Seth 20 years back when he had an inferior MI, was kept on medical therapy, rightfully so, and it did well for 20 years. He presented to us about 3 years back with class 3 angina, negative troponin, and ejection fraction of 40%. So if you look at this angiogram, it's a distal left main, heavily calcified vessel, and you see the whole vessel you can see even without angiogram. So you have calcified lesion extending from the distal left main to the mid LAD. The right is occluded with some collaterals from the LAD to the right. And if you see the spider projection, the ostium of the circumflex is also very nasty and very difficult angle of this ostium of the circumflex and LAD. So we need to treat this patient. He's 82 years old, not fit for CABG. We know that it's a high-risk case. We go 7 French groin. We never used Impella at that time, so IABP was the only thing we needed. Even with the ejection fraction of 40, I think the things go south very easily in these kind of patients. So when you think about IABP, I think you use it. So put in an IABP and we decided, of course, we'll do it under imaging guidance. And then we start with the rotablator. I'm not playing all the pictures, but we start with a 1.5 which crosses into the distal LAD with some difficulty as it was very tortuous. And after that, we protect the large diagonal and we do not dilate, but we first do imaging. We did not do upfront imaging because unlikely it would have crossed. And then we have 3 points of interest, point 1, point 2, point 3. So at point 1, we see a circumferential calcium with an MLD of 2 millimeters, some rota effects. At point 2, again, we see a circumferential calcium, somewhat nodular at some points. And in the distal left main, we see a classic calcified nodule from 11 to 1 o'clock. So we progress further step by step as we do. The MLD was 2. So we start with a 2.5 millimeter balloon, go up to 28 atmospheres. It fails, so it needs further plaque modification. There is failure of NC balloon. Should we use a larger burr? Probably yes for the distal left main part where there is a nodule, but if we do a 2 millimeter burr into the distal LAD, for this 82-year-old patient with occluded right, if he has a slow flow, he will crash on table. He just has an IABP. Probably IVL is the best option. In this situation, we see a circumferential calcium which may crack with the IVL. So that is what we do. We start with a 3 millimeter IVL balloon in the mid LAD and in the proximal LAD, which finally expands, and we follow it up with a 3.5 millimeter IVL balloon for the proximal LAD and the distal left main. We use this same 3 millimeter balloon into the ostium of circumflex, and this is where we have done our mistake, that we have not imaged this ostium of the circumflex. There is a nodule at the ostium of the circumflex, but we still went ahead and dilated this IVL balloon. And it is a very interesting picture. You see what happens on the left side. This IVL balloon ruptures into the left main, and there is a large hematoma into the left main, probably because of the nodular calcium, but thankfully we had already stented the proximal to mid LAD. So we just do a crush. That is what we were intending to do anyways. And then we stent from ostium of the left main to the proximal LAD here because of the dissection. We do a pot with a 5 millimeter balloon, do a kissing as is routine, and we get an acceptable result like this. We follow it up with the Ivus, which was very nice. For mid LAD, we got an area of about 9 millimeter square. In the distal left main, about 16 millimeter square. A very well expanding stent from the left main to the LAD and the circumflex. And this patient has done well on 2 years follow-up. The case 3 and the last is a recent case about a month ago. A 92-year-old man very physically active, presenting with class 3 angina, actually a yoga teacher, and grandfather of one of my medical colleagues who is now a gastroenterologist in Cleveland Clinic in USA, close to where Darshan comes from. Had inferior wall MI 20 years back, was managed medically, and now presenting with ejection fraction of 40%. This was his angiogram done at an outside hospital 1 month before the procedure, and we see a heavily calcified coronary tree with left main trifurcation disease. This is the aleocaudal projection. We see a very angulated ostial LAD, an aneurysm at the distal left main, very angulated circumflex, and occluded codominant right coronary artery. So what are the problems? He's a 90-year-old, he's heavily calcified, need to save all the branches, will need plaque preparation, will be a long procedure. We intend to use a 5th generation stent, and we use the best LV support that we can get. Over the month, he significantly worsened because of waiting and planning and all that, and he presented with class 3 dyspnea, EF dropped to 30%. And on the day of the procedure, his LV EDP was 28 millimeters of mercury to start with. We put in an Impella 2.5. I think it would have been impossible without the Impella this case. And you look at the distal, the proximal LAD, and more importantly, the distal left main now. The distal left main is now a subtotal lesion with a trifurcation, and it's going to be a long haul to treat this distal left main. So we wire with some difficulty, and we start with a 1.25 burr because I don't think anything else would have crossed. Immediately post wiring, his pressures dropped even on Impella. He was on support. So we start with a 1.25 millimeter burr, which is just the start of the story. So the 1.25, we do the distal left main, 1.25 in the LAD, it does not cross. We keep on burring, it does not cross. We keep on burring, it does not cross. It's 4 minutes at 200,000 RPM, it does not cross. So we know that diamonds don't last forever. They're anyways very expensive. So we consider halfway rota, but 2 calcified in the mid LAD also, so I think we would have struggled in the mid LAD part of it. We may balloon it then and then do rota. It may work, as Dr. Seth tells us, but sometimes it may not work also. So I changed the wire to extra support wire with a lot of difficulty after the first rota, take a new 1.25 burr, and again start burring. but again it does not cross. You keep on burring, and finally at 7 minutes at 220,000 RPM, the 1.25 burr finally crosses, and then you check whether you have a large dissection. You do not. You know 1.25 is too small, so you take the third burr in the procedure, a 1.5, and then you work on the mid-LED nodular lesion that you thought before you put in an imaging. So after you do a 1.5 millimeter burr, we do Ivus. So we check the mid-LED, we see some nodularity which has been tackled. There is circumferential calcium in the mid-LED. In the proximal LED, we see a lot of reverberations because of good rota that we have done. But as we come to the ostium of the LED, we see very large calcium burden. I will, with Dr. Gary sitting here, I will never say it's thick calcium, but large volume of calcium sitting there. And then we need to plan our strategy ahead. So we know we will crack the proximal LED. We know we won't be able to do a good job at the ostium of the LED with a balloon and at the distal left main. So we start with the IVL. But before IVL, we need to think what is our bifurcation strategy. So we don't have to lose any branches, so we put wires in all of them. If we have to do a trifurcation, we should never put 3 stents. So a trifurcation with the 3 stent is a failure of treatment. So I think we need to decide which one vessel if we want to stent, if we have to stent one of these two. The circumflex is giving collaterals to the right coronary artery, so probably the circumflex is more important in this case. Anyways, ramus is an extremely difficult vessel to stent nicely. So we dilate with a 2 millimeter balloon, the ostium of the circumflex, and we put in an imaging catheter. We see the ostium of the circumflex, which is coming here. It is also heavily calcified with calcified plaques on both sides of the carina with a minimal lumen area of 3.3, but there is some cracks in the calcium with the 2 millimeter balloon that we had used to prepare it. So we do not need OPN or IVL in this circumflex, thankfully. And it is a 2-stent case, definitely with so heavy calcium and small lumens. So we dilate the ramus with a 2.25 into 20 NC balloon with good result. So the ramus looks very nice. We remove the ramus wire, it'll be okay. And then we work with a 3.5 millimeter IVL on the LED and the distal left main, which works nicely. We stent the mid LED, then turn our attention to circ. We prepare the circ with a 3 into cutting balloon. After putting in a cutting balloon, we do Ivus of the ostium of the circumflex to see whether we have made any difference and is it ready to receive a stent. So after that, we see we have very good cracks in the ostium of the circumflex. It's a 3 millimeter vessel, so it is ready to receive a stent. We stent it with a 3 into 16 millimeter DES in a modified mini crush. So what is a modified mini crush? So after stenting, we don't crush. We post-dilate the stent with an NC balloon at 22 atmospheres before we do our first crush. After dilating the tight brass stent, we crush with a 3.5 millimeter NC balloon, and then we do Ivus into the LED. So why do we do this Ivus? To check whether the IVL had worked in the proximal LED, what should be the length of the left main to LED stent, whether do we need to cover the left main ostium as Dr. Seth was discussing, and whether we have crushed the stent in the circumflex appropriately. So this is the image after the first crush, and we see very nice fractures in the proximal LED, but so the proximal and ostial LED is well prepared with fractures. Left main to LED will be a 18 millimeter stent. The ostium of the left main is clean, does not need a stent, and we need bigger balloon to crush the circumflex stent struts which are hanging still in the distal left main. So we do a second crush with a 4 into 12 millimeter balloon in the distal left main, follow it up with a stent 3.5 into 18 from shaft of the left main to the proximal LED, do a pot with a 4 millimeter balloon, do kissing with appropriately sized balloons, and then we have an angiogram and we image from both directions. So I'll just let it play. This is from left main to LED. We see a very short neocarina, very well expanded stents in the left main to LED. So here we see a very short neocarina just close to the bifurcation. We have good areas, more than 8 in the LED and 7 in the mid LED. And this is the Ivus from left main to circumflex. I'll let it play since it's an imaging conference. So we again see it's very well expanded with very short neocarina, and ostial circumflex we have an area of about 7.6. After that, we do a final pot with a 4 millimeter balloon, and then we again do Ivus. So why do we do Ivus now? To check whether the final pot has disturbed the small metallic neocarina that we have, because if it is too distal, it will protrude into the circumflex, and again check the left main ostium as we were discussing. So this is the final run. So the neocarina looks all right. I'll let it play up to the ostium of the left main after disengaging the guide. We see the left main stent is exactly circular. There is no stent deformation. The ostium of the left main has no plaque, and there is no dissection at the ostium of the left main with an area of 12.3. So we have an appropriate angiographically and imaging guided result with a good result in the left main and ramus. And in the LAD, we have very good result in the LAD, very nicely expanded stents. So the patient did fine and was discharged 3 days later. So in summary, I will say imaging is the backbone of calcified lesion treatment. Superficial and nodular calcium is best seen on Ivus. And these are the two types of calcium which help us to decide whether we need rotabulator or plaque modification or not. After that, Ivus at each step of the procedure will help us in selecting the most appropriate device based upon the morphology of the calcium and the vessel size. And imaging improves efficiency of our procedures, but more importantly, safety for our patient. So to have best outcomes, we should use 5th generation stents. So you must be wondering, what is a 5th generation stent? So this is a line that I borrowed from Dr. Bill Lombardi at CTO Plus. So any 2nd generation DES implanted with imaging and optimization is a 5th generation stent, which decreases MACE by 2%. So it is not about orange or black. It's about whether we image or not, as Dr. Gary says. But more importantly, it is whether we want to have a good sleep or not. So if I can ask you to have a show of hands, how many of you want to have a good sleep after a long day in the cath lab? I think if the answer is yes, we should do imaging. Thank you.